And now it is my pleasure to introduce Dr. Horatio Kaufman, Director of the Dysautonomia Center at NYU.
Good morning, or good afternoon, wherever you are. Thank you for tuning in. I am Horatio Kaufman, the Director of the Dysautonomia Center at NYU, and it is my pleasure to welcome you to the 35th Annual Efd Day. As many of you know, the first Sunday in June every year for 35 years now, the Efd community meets at NYU to see each other, to talk about what's going on and what will happen. And this year is not different. Although we are meeting virtually rather than physically due to the pandemic, the spirit is exactly the same. And perhaps there is a silver lining to this pesky virus because it allows the whole Efd community to meet together online. And what a big community that is. So we have a very busy program today. I'm going to switch to my screen to show you a few things. You know, today, these are difficult times, but today we need to celebrate. And we have many reasons to celebrate and be proud of. First, we celebrate the extraordinary role of the Efd Foundation that makes the close bond between patients and families and the medical community possible. And they've been doing it for 50 years. You know, this is a very special foundation. Many board members are parents of affected children, but there's more to that story. Everyone with FD has a common ancestor. That's why it's called a founder mutation. Now, you know this story, but I want to tell it to the young. And like every story, it starts with once upon a time. 500 years ago, in the 16th century, a Jewish person in the north of Europe, where Poland is now, was born with a mutation in his genetic code. Now, the genetic code is like the Torah, full of instructions, detailed instructions to make the body grow and work. Each gene is a chapter of the Torah, and the Efd mutation is a misspelling in just one letter, in one word, in one sentence, like a typo. For example, like typing exit with a C instead of exit with a C. Now, with that misspelling in the genetic code, the descendants of that founder, of that first person, some of his descendants will have, as you see here, exactly the same misspelling, while others would not. And then the descendants of his descendants, some of them would also, as shown here in black, some of them would also have the misspelling and will carry that signal of FD. And then will generations and generations continue. And from the original around 10,000 of Jews in the 16th century in that area, the population grew dramatically to over 3 million people at the beginning of the 20th century. Now, the Pale, where they were living, got very, very crowded. So the Jews decided to emigrate. And from there, from the north of Europe, over 2.5 million of them emigrated all over the world. As you see in this map, they went to North America, Central America, South America, England, Israel, South Africa, Australia, and a number of other countries. And where are they now? Well, now the population, the families follow very closely the migration routes of the initial migration. So 134 individuals with FD are now in the US for a total of 350 individuals with FD around the world, or individuals diagnosed with FD. You see 130 in Israel, 17 in England, 12 in Canada, 5 in Argentina, and so on. There is a growing number in Mexico. Now there are 3 patients in Mexico. You hear a little bit about that soon. Now, around 134 or 135 of people with FD are younger than age 24, and the remainders, around 185, are older than 24. And as you see, there's around a similar proportions of boys and girls at all ages. Now, what is our role? Our role is to provide the best medical care for FD patients and their doctors 24/7 or 24/7 all over the world, 7 days a week, including Shabbat. So how do we do it? Well, we do it because we have a fantastic treatment center in the US, and not 1, but 2 treatment centers in Israel. One in Tel HaShomer with Ori Efrati and Bat El-Bar, and one in Hadassah with Alex Gilel. Now, within our center at NYU, we have, or in our center at NYU, we have a fantastic committed staff. We have Alberto Palma, who's a great neurologist, Lucy Norcliffe-Kaufman, who is basically in charge of almost everything, Patricio Millar and Bhumika Balgovin, autonomic disorder fellows that you met them and they take a lot of care of people with FD. Zenith Khan and Nadia Zelner, our nurse practitioners, you are going to hear from them today. The Martinez, Maria Kotrina, the data managers, the administrative staff, Barb Morgenstern, a biomedical engineer from Israel, all doing fantastic work. Now, within the hospital, we also have a strong network of doctors of all specialties that can take care of each of your problems, from ophthalmologists like Lila Raju, that's a corneal specialist, to Dr. Kaufman and Friedman in the ICU, Dr. Kasachkov, a fantastic pulmonologist that has taught us a lot on how to treat these problems. Dr. Levy, who's an actual a fantastic gastroenterologist, and Dr. Malter, the renal team, together with the transplant team that have now performed 4 kidney transplants in patients with FD. The last one is doing great. I so want to highlight Dr. Matou, Dr. Matalon, and Dr. Lons that were responsible for that. Of course, all this information from the subspecialties is coordinated by the FD team, which of course is the one that controls the autonomic nervous system that controls the whole body. Now, we also have mental health support that I want you to know about. This is through Lily Armstrong, a psychotherapist that does teletherapy, and this is supported by the Efd chapter in Montreal. And in addition to this, we also communicate with medical teams around the US and the world who see people with FD. They are doing the same and in close contact with our center, the Israelis, and all of them, you will hear from them today. I cannot list them all, but I want to highlight a few of them. There are pediatricians in New York, like Stuart Ditchik, that see many of our Hasidic patients. Helma Patel in Montreal, also a fantastic doctor. Gabriela Howard in Vancouver, who spent time with us a few years ago. Sue Laurent in London, and Valeria Riodici and Ellen Merete, 2 excellent neurologists and Queen Square that are doing a very dedicated job taking care of patients with FD in London. Dr. Nasson in Brussels, that also a fantastic doctor. A doctor in Kassel who had seen in Germany some of our new patients. We're also growing the field in Argentina and in Brazil, in Sao Paulo, where we were lucky to go. Carlos Mendoza in Florida, a fantastic ophthalmology now at Bascom Palmer that sees our patients. And I want to highlight one person. Alejandra González Duarte in Mexico that you see here. You see, 11 years ago, we were lucky that she spent a year learning and taking care of FD patients at our center at NYU. And you see, here is a certificate. So she's now in Mexico City taking care of patients with FD at the Instituto Nacional de Nutrición. And this is really a blessing because many of you are aware that there is a growing population of patients in Mexico. Not only Alejandra is taking care of them, she also was able to secure a very special equipment that now is only available in Mexico to study patients with FD. So Alejandra, keep the good work and thank you very much. I also want to emphasize Dr. Joel Gutierrez from Cuba. Joel Gutierrez is an extraordinary neurophysiologist. He comes every year and has been doing that for many years to New York to work with patients with FD. And together with us and other doctors from Australia, Dr. Macefield, based on work we did in FD, where we all received the first prize of the National Academy of Science in Cuba. So think for a second about that. Working on FD, a Jewish genetic disease, doctors from Cuba, Australia, and New York, and winning a prize in Cuba. Of course, Fidel had to agree. So keep the good work, Joel, and thank you very much. I also want to tell you very briefly the story of Lyndon Smith. Lyndon worked with Vaughan in Australia. He got very interested in the problem with coordination that people with FD had. So he decided to interrupt his medical studies in Western Sydney in 2016 and do a PhD. Where did he do it? He did it at our center at NYU, studying patients with FD. And he's now, the paper is just coming out, and he had fantastic results. What he showed is that although people with FD have a lot of trouble with balance in their legs, the arms, fortunately, compensate very, very well. So that article is being published now. These are the proofs, and it's very good news, fantastic work. Vaughan, thank you very much. And Lyndon, keep the good work. And all the community is grateful to you. Now, what I just showed you is one part of the story, because in addition to all the clinicians and nurses and medical care, there's a large team of basic research scientists around the world that are hard at work to find a cure for FD patients. You know, you're aware of Sue and Elisabetta at Massachusetts General Hospital. You know, Sue discovered the gene, that typo, that typing mistake that I was telling you. She spent years and years and found it. We are where we are now because of Sue. She has a big team and is still working, and of course you will hear from her today. We also have Frances Lefcourt, and with her team in Montana, Valerie Copy and Seth Walk. Frances is now one of the heads of our scientific advisory board. She does extraordinary work, has done mice models with FD, and she will show you some fascinating results in the retina that open the path to the possibility of genetic therapy. You'll hear a lot about that today. Also, Dragacic and Paula Dietrich, his wife, in Tennessee, also had produced a fantastic mice model in FD that is very, very useful for research. I also want to mention a new young researcher, Nadia Zelner, who has started a new state-of-the-art lab in the University of Georgia. She's working on stem cells produced from people with FD, from cell cultures. This work promises to be very, very rewarding. Nadia, keep the good work. You have all our support, and thank you for doing it. I also want to mention Adrian Kriner, who is here in New York, in Long Island. Adrian is one of the top world scientists in genetic genetic disorders. He has discovered something called an ASO, a small molecule that is leading the way in curing another genetic disease, and we hope that Adrian will help us do the same with FD. I also want to mention Claudio Punzo in Massachusetts, working in genetics, Franco Pagani in Italy, and Miguel Weil, of course, in fantastic scientist in Tel Aviv. From you will hear a lot of details today. Now, what do we do with all this information? Well, we do a number of things. First, we try to put it all together and produce continuous guidelines to update physicians around the world who take care of patients with FD. And also, we published all the new findings. One that is not here, that we just got the communication today, is that our big study on carbidopa, a drug that we believe is very, very useful for the management of the blood pressure and the crisis in patients with FD, that big trial has just been accepted and it's also going to be published. So all this is to keep all the community up to date of what's going on. Now, I hope I gave you a little bit of a perspective of how this work is occurring. And I want to emphasize that each one has a role. It's like a symphonic orchestra. You see, in order to play the music well, everybody has a role. From the conductor that appears to move his arms all the time, to the panderet or the maracas that only move occasionally, regardless, they are all crucial to the music. And of course, you are in the orchestra too. And the orchestra, my friends, is playing for you.
You're hiding out so painfully. See yourself come out to play. A lover's rain will wash away your envy and your fear. So have no envy, no fear. When your sister turns to leave, only when she's most in need. Take away the cause of pain by showing her we're all the same. Have no envy, no fear. Have no envy, no fear.
Thank you. So I hope I got you in the spirit and got you prepared for a fantastic day today. So what I want to do now is to give you a very brief message of our nurse practitioners.
Hello everyone, my name is Zenith Khan. I am a family nurse practitioner here at the NYU Dysautonomia Center. I started working here in August of 2019, and since then I've been constantly blown away by the compassion, the perseverance, and the resilience that FD patients and their families show. I have learned so much from you all, and what I truly love about the FD Center is its dedication to providing and supporting FD families to live their fullest possible lives. I'm grateful at times like this we're able to still come together, and I look forward to meeting you all. Thank you. Have a nice day.
Hi, my name is Kaya Dalamo. I'm a doctor of nursing practice and one of the nurse practitioners at the Dysautonomia Center. I joined the practice in October of last year, and since then have met many wonderful people and their families living with FD. Right from the beginning, I noticed that there was this deep sense of community and connectedness, almost like I'm working in a big family. And it's been a joy taking care of the members of this community, and a true honor to be welcomed so warmly by you. For those that I haven't had the opportunity to meet yet, I hope to meet you soon. And I wish everyone well and to stay safe during these times. Thank you.
Okay, so thank you very much for that. And now I have some breaking news. I want to, before we continue, I want to make certain that I update you on COVID. This is another thing we are very grateful for, is that our FD patients are doing much better, or have done much better than we feared. Only 4 patients were tested positive for COVID-19, and they're all fully recovered. Only one of them was admitted to the hospital. This is all around the world, and he did great. The others that were not admitted to the hospital also did very good, and you will hear from one of them today. We provide constant update information in the www.dysautonomiacenter.com. As you see, there are articles on the eye and the lungs, how to stay healthy during the COVID epidemic. So keep taking all the precautions not to be exposed to the virus, and everything will be fine. So what is next? Let me start the whole session today by giving you the clear objectives like we have them. The number one is that we know, thanks to Sue, what the genetic problem in familial dysautonomia is. Second, we know of at least 3 ways that we can fix that, and we believe they could work. So you will hear about that today, but we need your support and determination. I assure you, we can do this. We will do it in our lifetime. We will get to the promised land. Thank you, thank you, thank you, and have a fantastic day today. We are going to be listening to all your questions. Thank you.
Good morning, good afternoon, or good evening, families watching at home. My name is Lucy Norcliffe-Kaufman, and I'm the Associate Director of the Dysautonomia Center. Thank you, Horatio, for such an extraordinary presentation. You always set the tone for FD Day. It's always been a dream of mine to make FD Day an international event, and today we're starting with that now, which is really exciting. It's my pleasure to introduce one of our esteemed collaborators, a pediatrician in Israel, who is resourceful, smart, passionate about her patients, and takes care of many of our patients with FD in Israel. Please welcome a message from Dr. Bat Elbar.
Hello, my name is Dr. Batel Baraluma. I'm a pediatric pulmonologist from the Sheba Medical Center. Maybe part of you remember me from around 7 years ago when I did part of my training in the NYU Dysautonomia Center. There I worked with Professor Felicia Axelrod, with Professor Horatio Kaufman, with Lucy. And after a period of very enlightening and interesting experience, I came back to Israel, and together with Professor Efrati, who's the head of the pediatric pulmonary unit, we established together a new FD center in Israel, in Sheba. Today we follow around 60 patients, and we came up with a very, very diverse and distinguished team of doctors that include me, the pulmonologist. We have a gastroenterologist, a neurologist, an expert in blood pressure, and a cardiologist. Also, we have our physiotherapist, chest physiotherapy mainly, a nutritionist, psychologist. We have an FD coordinator. We have our social worker, and together we try to give the best medical care that we can. We do that by inviting our patients every 4 to 6 months to do pulmonary function tests, to see our physiotherapist, to see the nutritionist, and we try to give a platform for a good and healthy way of life and maintain a good quality of life. And and of course, we encourage our patients to see the psychologist to maintain also a good mental health. I would like to add also that we work with full collaboration with the NYU Center in New York and also with Hadassah. We share information, we share data, we also do some research together. And after presenting our center, I would like to wish you all a very good FD day and hopefully see you soon. ביי. מה העניינים? מה נשמע? איך הולך באמת? הכל טוב מאמה? חזרת כבר לבית ספר? שלום חמוד. אני אמדוד לך לחץ דם, אתה מסכים? אוקיי, אז אני אשים לך שרוול כזה על היד. השרוול הזה בכל התפתחות שלה. ואז תראה פה על קצת את הלחץ דם שלך. והמשקל אבל אותו דבר? כן? זהו? רגע, רוצה שאני אגיד לי.
Hello, my name is Nir. I'm one of the physiotherapists here at our center. Our treatment of the FD patients is composed of the physical part, and exercise is important for all of us, and the respiratory part. The respiratory part is keeping the lungs clean, avoiding exacerbations, and keeping volumes with inspiratory trainers and PAP masks, mechanical cough assists, and BPAPs. I wish you all a very good FD day and good health.
Hi, my name is Mary Fascha and I am the social worker of the Dysautonomia Center in Israel. And I'm very glad to be here in this FD day. It's important that we have now the opportunity to join all the FD centers in the world, and I'm happy for families and FD patients. Thank you.
Hi everyone, my name is Bar. I'm a clinical pharmacist and I work in the pulmonary pediatric unit. And as part of my job, I work with the FD patients. And as you know, many of you get a lot of medicines on a regular basis. And my job is to see that there is no drug interactions, that no side effects, and basically that each one of you get the best treatment for him.
Good morning, everybody in New York. I really want to congratulate you in this special day, especially the FD patients and their families. All the best from Israel and from the Edmond and Lily Children's Hospital Sheba, the greatest hospital in the Middle East. Bye bye everybody.
Hello. Hello. תעשי ככה. Hello.
Hello.
נעשה ביחד?
Hello. Thank you, Dr. Batelba, for such a beautiful message from your team there. Of course, it takes a village to take care of FD patients, and we're so proud to be able to work with some of the smartest clinical scientists that there are leading this effort. Continuing a long line of legacy of outstanding medical care of patient familial dysautonomia at Hadassah University, please welcome our next speaker, Dr. Alex Gilel-Hillel.
My vision for the FD Center requires a multidisciplinary approach to allow the best possible care for patients with complex diseases such as familial dysautonomia. Our center has a dedicated nurse, a social worker, that provide constant support for families outside regular clinic visits. Our dietitian, who specializes in feeding disorders, brings her expertise working closely with a dedicated pediatric gastroenterologist to address complex GI issues. Additionally, our physiotherapist works both in clinic and during hospitalizations with our patients to ensure pulmonary and neurological physical therapy. Our core team works closely with a nephrologist, a hypertension specialist, a neurologist, a spine surgeon, and an ophthalmologist, all of whom are dedicated to treating patients with FD and dealing with their unique problems. Each clinic visit includes regular follow-ups, in addition to extensive blood work, sputum culture, pulmonary function testing, and the patients are seen by the many specialists based on the unique set of problems they present. We are also incredibly involved in the research in the field of familial dysautonomia. You may hear today about the natural course study we participate in, led by the NYU Center. We also conduct clinical studies on the nature of sleep problems in patients with FD, the optimal approach to reflux treatment in infants with FD, and many more. I wish to congratulate the organizers of this wonderful day, and I hope we will be able to hear and learn new things today to continue progressing the care of FD patients together.
Hadassah has more than 30 years of experience in treating familial dysautonomia patients. The center at Mount Scopus is one of the leading centers in the world, collaborating with other centers both nationally and internationally on numerous clinical and academic topics. The multidisciplinary approach at our FD center enables excellent treatment for our patients, both during routine follow-up and when in need of hospitalization.
Thank you for that great message from our collaborators in Hadassah. It's my pleasure to introduce the final speaker in our clinical session this morning, which is a man who I have the pleasure of working with every day. Not only is he a dedicated physician, but he's behind every single one of our successes when it comes to clinical research. He's smart, he's always inspiring, he's truly amazing. Please welcome Dr. Alberto.
Good morning, everyone. I'm Alberto Palma. I'm one of the physicians and neurologists at the FD Center at NYU, and I'm delighted to be here. It's a pity we're going to do FD Day in person as we've done in the past, but at least this is better than nothing. And I'm sure many people are watching us from home, and I think it's a great chance to get together and discuss and talk a little bit about the situation and about the updates on FD as every year, right? So I want to introduce my talk. My talk is going to be a little bit a mix between clinical and research, right? And I know Dr. Kaufman has summarized all the clinical updates on FD, and then we'll have another session later on the research updates. So my talk is going to be very short and is intended to be like a transition between both talks, right? So, and let me share my screen because I'm going to have the slides here. There you go. So it's about clinical care and clinical research in FD. Now, the thing is that many times when patients come to the FD center and we ask them to do procedures, many times they ask us, well, is this clinical or is this research? And you know, that's a very reasonable question, particularly in common diseases, right? For instance, many people have diabetes, and for diabetes, the clinical care of a patient, what is actual clinical care, is very well defined, and what is research is also defined and different at the same time. So there is like a Chinese wall between clinical care and research, right? But this is mostly for common diseases, right? Now, in rare diseases like in FD, this is not the case, you know, and clinical and research are usually entangled. So it is not possible to separate many times. And whatever we do for clinical care has implications for research. And also, when patients participate in research, it has direct implications in their clinical care. And I have two examples, right, to show you how this is the case, right? And again, this is a repetition. Research procedures can inform decision-making in clinical care. Information collected for clinical purposes is used to design research procedures, and both in rare diseases, both research and clinical care, it's impossible to disentangle. So please don't ask us anytime, is this clinical or is this research? It's the same, it's the same. For instance, let me explain to you a little bit. You know, at the Efd Center in New York, but also in Israel, every single piece of clinical information that we get from patients, and it can be in office visits or phone visits or questionnaires or telemedicine visits or medical records from other doctors, all that information is collected and entered in our database, right? And you can see here how our database looks like. It has information on everything, and I won't to bore you with the details, but we enter everything, right? Everything we get from you is entered in the database. And you know, I won't talk about the natural history of FD. That's something that Lucy will talk about, but that's the backbone of the natural history study, right? That's how we collect information from every single patient, and we follow patients over time. Now, definitely, and we collect information from every patient, and this is an example, right, of how our database looks like. And here you can see how simple it is for us to track the evolution of, for instance, the blood cells, right? This is the CBC of this patient. This is a fictional patient. It doesn't exist. And you see here how we can track their values over time. And this is an example, again, for the blood cells, for the CBC, for the complete blood count, but we can do that for every single value, right? So, and again, this is clinical information entered in our database, but of course, it's used to answer both clinical and research questions, right? So many of you ask us, oh, how many patients with FD have epileptic seizures? Or how many patients with FD can walk at age 30? Or how many patients with FD have received growth hormone? Or how many patients with FD have had cancer? Well, those are research questions in a way, right? And again, they may not be, it's difficult to disentangle. My point here is that all the information we collect over the years from every single patient, and we have around 700 patients now, every single patient ever diagnosed with FD that we have knowledge of is entered in the database, right? And we can use that information to answer all these questions. And these questions have clinical implications, but we can get research papers from those and research findings from those questions, right? And this is a real example that we did, right? So we asked one of these questions, okay, how many patients with FD have breathing problems during sleep? So what we did is we ask the database, we look at the database, we look at the information from all of our patients that had undergone sleep studies. And the answer was pretty surprising, right? So up to 91% of pediatric patients and 85% of adult patients have some degree of respiratory problems during sleep. And again, is this research? Sure, it's research. We got a research manuscript, it's published in a research paper, so this is clinical research, but this has immediate clinical applications for patients with FD, and that's why now we are so insistent that every single patient needs to have a sleep study, and they may most likely need to use the CPAP or the BiPAP. I won't talk too much about that today, but that's something we've discussed other years and that we definitely discuss when you guys come to our annual visits in New York or in Israel. There is another type of interaction. Before I talk about how we use clinical information that we collect during office visits, and we use that for research purposes. Here, the second example I have here is a little bit different, right? Is how by collecting research information, we can make clinical decisions, right? And one way to do this is with surveys, with questionnaires, right? I know many of you, or you know how we ask you to fill out a questionnaire every time you come to the FD Center here or in Israel to have an updated information on your clinical medications or allergies or whatever. That's not what I'm talking about here. What I'm talking about here are dedicated, specific surveys that we may send you occasionally from time to time, right? And we did that recently, a year ago or a year and a half ago, to ask everyone about gastrointestinal problems. Some of you may remember that survey, right? So in fact, we sent it to 202 patients and families. So all of the patients that we had in our database that are still active and families active, we sent the survey. So you received it, but only 38% answer, right? Only 77. I'm not gonna admonish you for that, but that's another topic. My point here is that, you know, gastrointestinal problems, sure, we know that many patients have gastrointestinal problems. Many patients have crises, many patients have retching, vomiting, but not all the gastrointestinal problems are limited to crisis, right? And that was the goal of this survey. The goal of this survey was to determine what other GI problems FD patients have. And we were really surprised with the results, let me tell you, because, you know, 97% of FD patients have bothersome GI symptoms. And again, this is different from FD crisis. This is different from retching and vomiting. I'm talking about bloating, reflux, indigestion, swallowing problems. And for 42% of patients, these were the most bothersome symptoms. Worse than the balance, worse than than vision problems, worse than dizziness, worse than fainting, worse than swallowing problems. You know, almost half of the responders of this survey told us that the GI symptoms, other than the crisis, were their most bothersome problems, right? And, you know, of course, in clinical practice, we see that, we hear that when you guys come to the office visits, but it is much more powerful to have a huge sample of 77 patients that answer a specific survey. So my point here is surveys or research instruments can be very useful. And why is this useful when we get this information? Well, because now we pay much more attention to gastrointestinal symptoms, apart from the crisis, when you guys come into the clinic. And we are now involving more GI doctors, right? And we are trying to understand why is this happening in FD, why patients with FD have indigestion, why people with FD have bloating, why patients with FD have reflux. Well, it's not well understood. Sure, I mean, we know it's because it has to be something to do with the autonomic nervous system or with dysautonomia, but we need to understand that better eventually to develop treatments, right? And you know, the ultimate goal would be to develop guidelines for the treatment of gastrointestinal complaints in patients with FD, the same way we did with respiratory problems. You know, we did exactly the same with the lungs and sleep, and we put together a huge team of experts, including not just the doctors at the center and the research team at the FD Center, but also our colleagues from Israel and also a bunch of respiratory physicians. We sat down together, we reviewed all the clinical research that was available on the respiratory problems in FD, and we came up with specific recommendations, right? And this is a great example of how research in FD has immediate clinical consequences, positive clinical consequences, because now every patient with FD in the world can print these guidelines, show them to their local doctors, and their local doctors will be completely updated on what to do with respiratory problems in patients with FD, right? Regardless of whether they are in Germany or in the UK or in Australia, right? So they don't have to be at NYU or in Israel to receive the most cutting edge respiratory treatments, because they know what to do if they read these guidelines, right? So, you know, that's all I have to tell you. It's just for you to think or realize that every time we collect clinical information on you, it's going to be used for research purpose. And every time we do research, or we ask you to do research with surveys or with other projects, it's going to be eventually applied to you or to other patients with FD sooner or later, right? Clinical information is used for research purposes, and research results inform clinical decisions. So please, number one, don't ask us ever again if this is research or is clinical. It's usually both, right? It's usually both. Number two, when you get a survey, please answer the survey. It is very useful for us. It is very useful for us, and it will be useful for you, okay? And that's all I can tell you for now. I'll be happy to answer questions later in the Q&A section, and I'm sure the research part of the meeting is going to be very, very interesting. Okay, so I'm looking forward to answering questions with you guys.
Thank you very much, Dr. Palmer. I hope you found those talks informative and lots of great advice. Please know that we're here as your clinical research team and your doctors to guide you with whatever you may need, and our services are available 24/7. I would like to move now to an exciting part of the program in which we welcome our specialist physicians in familial dysautonomia to answer your questions and provide you feedback on some of the pressing issues that you've asked us that are your concerns. When you filled in the survey for FD Day, you filled in a number of questions that you wanted to pose for us. So we'll kick off with some of those. I would like to introduce our speakers that you've all seen. You see Dr. Alex Hillel, we have Batel Ba who joined us, we have Dr. Alberto Palmer and Dr. Horatio Kaufman. So let's start, hopefully, if you're all ready, with the first question that came in from our families. So we've obviously things are quite dramatic in New York City right now, and a number of questions that have come in are related to the COVID epidemic. And many families have asked us, are there specific precautions people with FD need to take to be able to stay safe at the time of the COVID-19 pandemic? Dr. Kaufman, I'm going to pose this question first of all to you.
Well, first, I want to tell you that you have to follow exactly the same precautions that your area is taking, and so far everybody's doing good. So keep focused. Try not to keep social distance, and everything will be fine.
So now, Dr. Kaufman.
Yes. I think maybe, Alberto, do you want to comment about this?
Well, it's sure. I mean, it's essentially what Dr. Kaufman mentioned, right? Make sure you follow your local governmental recommendations, social distancing. And, you know, many patients and many families are asking us whether FD patients are at increased risk for COVID. And as far as we know, they are not. I mean, there is nothing in FD that may pose higher risks. At the same time, any precautions should be followed, right? So cleaning hands, social distancing, masks where that's advised, and, you know, keep calm. And if you have any questions, feel free to call us, email us, or call the team in Israel, right? And we'll be happy to provide to you with specific recommendations.
Thank you to both of you for those answers. I know we have a weekly meeting with our nurse practitioners, and we have a task force where we discuss, are we ready to come out with new guidance for patients with FD? And whenever there is something that we feel we're ready to put out there for the entire population, we will give it, we will have an article on our blog, and we will use the resources of the foundation to help distribute that information to patients so it gets into your hands. So remember, sign up for our blog and sign up to the foundation so you can stay in touch with those regular updates. Okay, next question, please. So this again relates to the situation that is changed our life quite dramatically, at least in New York City. And that should patients with FD be attending clinic visits or use at-home video calls to connect with their doctors? Dr. Palmer, I'm going to throw this question over to you.
Right. Thanks, Lucy. So absolutely. I mean, right now the situation is making us changing rapidly to telehealth visits, and that's something we are already doing right now, right? So because due to the circumstances in New York City right now, NYU is not allowing to see new patients. So that's what we are doing right now, meaning we are doing telemedicine visits, and that doesn't mean we are not
Perhaps
able anymore. That doesn't mean you can call us. I mean,
Lucy,
we
can
are
I
there.
comment
And
on it?
absolutely. Go ahead, Dr.
Yeah,
Kaufman.
go ahead, Horatio.
Oh, I'm sorry. Is my I didn't know if I was online. So look, Alberto is absolutely right. I just wanted to emphasize that is both that are useful, and there are a number of things that can be done in this way, and others that require coming to the office. But we provide both and try to do the best with both options. So both of them are available, and I presume that Bat and Alex are doing the same, right? Offering a combination of both things to provide the best possible care.
So, Bat, Alex, how is the situation in Israel? Is it quite different, or do you want to tell us how you're coping with, or maybe you're less impacted? But Bat?
I think that now we're in a more now we're seeing patients in the hospital. So because in Israel the epidemics was less than in the US, so now everything's back to almost everything is back to normal, and we started like 2 weeks ago to see patients here in the hospital, and we're doing good.
That's great to hear. That's great to hear. And I know when I talk with both of our nurse practitioners, they say if you have any questions, please reach out to us, please talk with us, and they'll be happy to discuss things on like a case-by-case basis because everyone's situation is quite different. So can we have our next question that came in? Which is, are there any new patients with FD? We're not aware of any new patients with FD, but I wonder, Alex, do you want to comment about the new patients that you might be encountering in your clinic?
Right. So you know that, but I'm not sure how widespread this knowledge is, but we do have one or two new patients almost every year now for the last couple of years. And for a combination of reasons. Some people are unaware of the Jewish heritage, some are unaware of the genetic screening tests, but basically what we experience is at least, as I said, one or two new patients, and this allows us to re-examine the old thesis of familial dysautonomia treatment. For example, looking at the guidelines respiratory care, we're trying to see how these new guidelines fit the old thesis of fundoplications, for example. So it's actually an interesting area to live through in FD.
Very, extremely. So if you have any questions, you can post them live to us on our chat feed, and they will come in, and you can reach our experts and get answers. So can we have our next question, please? How pervasive is anxiety in the FD population? And Bat, I'm going to pose this first of all to you. What's your experience?
I didn't hear the question, sorry.
How pervasive is anxiety in the FD population?
I think that because of the situation that was quite calm here in Israel, so everyone stayed tuned to what the public minister health instruction were, and we had no patients, no FD patients in Israel. So I think that the level of anxiety is not that high in Israel. I see that now that we open the clinics, patients don't hesitate and they come and they do everything they need, pulmonary function tests, blood work. So I think that here in Israel, the level of anxiety is not that high, hopefully also in the States.
Well, I'm delighted
we have
to hear that. I thought
so we have
I thought the question was more general, that anxiety is very common in people with FD. I just want to emphasize to all of you that anxiety, like Alberto was referring to about gastrointestinal problems, anxiety is as pervasive. So you are not alone.
So, Dr. Kaufman, do you want to comment a little bit about how anxiety might manifest in someone with FD? Because quite often the signs and symptoms of anxiety are quite dramatic, right?
Absolutely, Lucy. And many of you are aware that what we call crises, these autonomic manifestations of feeling difficulty breathing and hypertension, tachycardia, vomiting, many times those are triggered by anxiety. So anxiety is very prevalent, and what we are all working, and I'm sure Alex and Bad are doing as us, in methods, in therapies that could work in reducing anxiety. And perhaps the even telemedicine and psychotherapy, surprisingly, is powerful. So it's important to know that anxiety should be addressed and should be treated. And anxiety itself can be the cause of many of the symptoms, like even the gastrointestinal, the blood pressure, and other symptoms can be in FD produced by anxiety. Like in the people that don't have FD, but in those with FD, the same is even more pronounced.
So, I know that we are incredibly lucky that with the support of the Montreal chapter of the Dysautonomia Foundation, we're able to have a psychotherapist, Lily Armstrong, that works with us and can take a caseload of FD patients and help them through some of the challenges that they may be having. Dr. Palmer, do you want to comment a little bit on some of the treatment approaches we have for anxiety?
Sure, Lucy. So first of all, we need to address what are the potential causes of the anxiety, right? Sometimes these causes can be identified and can be reversible, right? And that's something that can be very individualized. That's the very first step. At the same time, we always have non-pharmacologic treatments for anxiety, right? And these can be targeting a number of different types of treatments, right? You have mindfulness. Many people improve with yoga therapy or with relaxation techniques or with breathing techniques. All these non-pharmacologic or behavioral techniques, these are really, really helpful for most patients. And they are, many times they are undervalued and underused because people are not aware of their existence and people are not aware that they can really be really helpful. And eventually, some people require some medications, absolutely. At the same time, medications can have a number of side effects, and that requires also a personalized treatment to make sure we minimize the side effects. And some medications commonly used to treat anxiety disorders can have dependency and addiction problems, right? So, just to send a message that there are many more treatments other than medications for mood disorders and for anxiety problems, and we could help you with that.
So a hot topic, definitely something that we needs further exploration. It's complicated to treat, but we're there to help. So please, any questions that you may be having, submit them in our chat feature. We'd love to get to them. And if we can take our next question. So can patients use Prosthetics for crisis? And Dr. Palmer, I'm going to turn this one over to you because I know you've done some phenomenal work in helping us understand the effects of Prosthetics and how it might be used for a crisis.
Right, absolutely, Lucy. So the short answer is yes. I mean, we have been using Prosthetics for a number of years now. Prosthetics is essentially very similar to Clonidine, but it has a number of advantages, right? The number one is that it can be used intravenous, which is something that we cannot do with Clonidine. The second advantage is that its mechanism of action is very rapid. It kicks in really, really fast, and it weans off also really fast, which is also an advantage because we can target the dose and we can adjust the dose of Prosthetics very easily. There is one disadvantage though, that because it is intravenous, only people in the hospital setting can use it, right? So it's something that we are using now more and more for patients coming into the ER and patients coming into the hospital for crisis. That's our medication of choice right now, right? So, and more we are teaching other hospitals other than NYU how to use Prosthetics for patients with FD when they go to their local hospitals or local medical centers, right? And that's something that works really, really well.
You know,
That's great to
in a
hear that there
few
are options.
instances,
Dr. Kaufman, many of the families at home may not be aware of how Prosthetics came about as a treatment, and you were there. I wonder if you'd like to share the story.
well, you caught me off guard as usual. Yes, it was a father. There was a father. He was a father of a patient that is an anesthesiologist, and we were trying to get the crisis of his son under control. And he's the one that said, "Look, I'm using Prosthetics all the time. Try it." And I thought it made a lot of sense. And the rest is history. And we've been using it since that time. One thing I want to comment, a possibility is that, and we've used it in a number of cases and it's published, that it can be used intranasal. That's the way it's used in India, in rural areas. So we copy that model and tried it in a number of patients, and it worked intranasal. So for an emergency or in a situation when the emergency room is not equipped with IV equipment, and in some smaller towns they may not be, it can be used intranasal. So that is published and will also be available in the blog. Lucy, I'm sure you can make sure of that if somebody is interested in using it acutely in the ER or even at home, as has happened in New York.
Is there anything that you want to add in that is different about the way you treat the crisis of your patients that you encounter?
No, I think that we do basically the same things. We give Clonidine if it's not in the setting of the ICU. So we give Clonidine, we give sometimes benzodiazepine if needed. Of course, only when the patient is monitored and we see that everything is okay. It's important to see that the patient is hydrated and all the salts in the blood are okay. And hopefully doing that, we hope that the patient will stay out, will
stay out of trouble, and we always do with your help.
Perfect.
So our next question,
Right.
please. Oh, this is a hot topic, and I'm so happy that we have two expert pulmonologists joining us on the panel today. So this is their question, and it's a vitally important one, which is how best can patients with FD take care of their lungs? Bat, do you want to give us your thoughts?
Okay. So I think that there are three important things that we have to do regularly in order to take care of our lungs. The first thing is to treat promptly if there is some kind of chest infection. If there are signs of cough, fever, then we don't have to wait. We just treat with antibiotics, sometimes with systemic corticosteroids if needed, and we have to treat that promptly. The second thing is bronchodilators therapy. Some of you really benefit from this therapy, and we can check that by doing pulmonary function tests prior and after administration of some kind of bronchodilators that you know, like albuterol, and to see if you benefit from that. And if you do, you can even use that daily to expand the lung and have better volumes. But the most important thing to maintain healthy lung is daily chest physiotherapy. There are several ways to do that. Our recommendation is the muscle insufflator, exsufflator, or cough assist, which also we know that the cough in FD is not very efficient, and sometimes part of the lungs are a bit collapsed, and that is the best way to ventilate the lungs and to take out all the sputum that needs to go out and to maintain healthy lung. And we have a short video showing how to do that.
My name is Gil Sokol. I'm a senior physiotherapist in the pediatric pulmonary unit. There are four main goals in keeping healthy lungs in familial dysautonomy. First goal is to improve the respiratory muscle strength. The second goal is to improve the lung volumes. The third goal is to improve chest mobility. But above all, the most important goal is to produce an effective cough. Improving respiratory muscle strength is done by MIT, Muscle Inspiratory Training, which acts like gym for the chest. By breathing against resistance, we are strengthening the muscles of the respiratory system.
עכשיו ניקח את זה, נניח את זה על הפנים ותנשמי עמוק. יופי, עוד הפעם. כל הכבוד, את אלופת העולם. שתי ידיים, להניח את זה על הפנים ו5 פעמים עמוק. יופי.
Improving lung volumes is done by breathing exercise by using an incentive spirometer which called tree flow.
עוד הפעם. ועכשיו חזק, 2. נהדר, בואי נהפוך. תחזיקי. ועכשיו בשאיפה, תרימי כדור אחד. נהדר, 1. 2. 3. תנסי עוד הפעם חזק. יופי. פו חזק. ולהשתעל. עוד הפעם. את נהדרת.
Improving chest mobility includes active stretching and mobility exercise that can be done independently or with the guidance of a physiotherapist or a trainer. Cough is the most important defense mechanism of the lung. In order to be able to cough effectively, we use a machine which is called mechanical insufflator-exsufflator that can produce an effective cough.
עמוק.
Wow, thank you for that amazing video. But such a vital piece of the puzzle to help keep FD patients' lungs healthy. Alex, I know you're also an expert in pulmonology. Do you want to add something?
Yeah, actually, thank you, Lucy. I completely agree with all that Bud said, and our strategy is pretty much the same. What I want to emphasize is that a lot of the lung problems that we see in patients with FD are bronchiectasis, meaning they're areas of the airways that are damaged from recurrent aspirations, from infections, pneumonias, etc. And very important part in the treatment is to keep those areas completely clear of infection and inflammation, and daily physiotherapy is one of those things. Inhalations with the bronchodilators, with the saline, again, very much help in clearing the excess phlegm that accumulates in the lungs. And importantly, is the follow-up that we do with both lung functions, as Bat showed in her video, pulmonary function testing, and with serial chest imaging, whether it's CT or X-rays once in every 2 to 3 years, just to assess the degree of progression and decide how aggressive we want to be with the lung clearance techniques. And sometimes we even have to use chronic antibiotics just to keep the lungs protected.
Thank you for that. I mean, it's really, for us, it's incredibly uplifting to see that we have respiratory experts on our team, because their approach to FD is always very multidisciplinary, right? So having you guys as part of the team is just an amazing opportunity for us and for the patients. I'm going to pose a few questions that came in through our live chat right now. One of them was, is Prosthetics a replacement for Clonidine? Dr. Kaufman, do you want to take that as a question?
Sure, we think is a better form of clonidine. It's essentially a way to use clonidine with being able to control, like Alberto explained before, the effect at a more minute-to-minute level. That is useful, but it also requires much more care. And the best thing is to avoid all pharmacologic treatment for crisis. All drugs are, they can be effective, but they should be used only as last resource. So the answer to the question is, does it replace clonidine? Yes, it does. It's a similar type of drug.
So another question that came in from our audience refers really to the issue of getting hold of carbidopa if you're not in the US. And I know, Dr. Kaufman, I'm going to throw this back at you, because I know you've been very instrumental in reaching out to and create your contacts in places like in England, in Queen Square. And do you want to mention a little bit about how patients can have access to carbidopa if they're not directly within the US?
Well, perhaps the best thing to do is to let us talk with your doctors, because the drug is always available locally. This is a compound that has been around for 40 years. We are just using it differently. Before, it had never been used alone. It was used for something else. The way we do it has nothing to do with the way it was used for Parkinson's disease. So it has no connection with that, but the drug is available. And in Israel, I'm sure that Adrian can tell you exactly how to do that. So, and in any other country, we'll be happy to talk with your doctors and try and make it available.
Fantastic. Thanks for that. So some great questions coming in about the pulmonary care of patients with FD. Alex, I'm going to pose this one to you. Does playing a musical instrument help?
It's actually a fun question. It always helps, because it helps psychologically, I'm sure. But interestingly, Alberto mentioned the study about prevalence of sleep problems in FD patients, and as we know, a lot of those patients have problems with respiration and apneas during sleep. And there was a very small study, but I think we can learn a lot about it, in patients with sleep apnea that played didgeridoo. I hope I pronounce it correctly. That's the tube Aborigines in Australia play, if you know what I mean. Mm-hmm. And they showed that playing this instrument improved the tone of the upper airway, so the sleep apnea actually improved. So referring from that, my guess would be trumpet or anything that you can blow, just like the cuff assist, would probably train the upper airway muscles and be of benefit.
I think we should use shofar.
Yes.
Yeah, that's true.
A shofar, Alex. We could use it, and then we could report it every day. So perhaps that should be one of the conclusions of this section. You need a
So
shofar
we have
every
time
morning.
for one final question, which again relates to plenty of questions coming in about pulmonary care, which is great to see you guys are on it and you're thinking about it and you're doing what you can. But what's your feeling about the chest vest?
She didn't hear
Are you
the
asking
question.
to Bart?
Yes.
I don't think, but
Maybe she
but
froze.
do you use the chest vest? In my
She
experience,
froze.
she's frozen.
I
think she froze.
Yeah,
mine
perfect.
too. Yeah. Well, I'm sure. Well, I'm sure not. I'm presuming because I know Bat that she's going to say she likes it, and is going to tell you how useful it can be, but it's not everything.
Fantastic.
So are we? Here I have 0 time.
So
I think we have some.
That concludes our question and answer session for the clinical panel. I want to thank each of our clinicians for being available, for answering your questions, and for their all-round awesomeness in treating FD. And it's a pleasure to work with all of you.